Welcome to our live webcast, Popular Joint and Bursa Injections Using Ultrasound. Thank you for joining us. My name is Heidi Border, and I'm Senior Meeting Planner for Azure Pain Medicine and will be the host for tonight's webinar. We are joined tonight by our moderator, Dr. Dennis Patterson of the Nevada Advanced Pain Specialists in Reno, Nevada, who is going to introduce tonight's topic and speakers. Welcome, Dr. Patterson.
Hey, thank you for having us tonight, and look forward to tonight's presentation and having my friend and colleague, Dr. David Russo, help out.
Great to be here, Dennis.
Thanks. Well, what I'm going to do is I'm going to pull up our slides here, and we can get started going through the presentation. So as Heidi was saying, here are Dave and I in the flesh. I'm currently in Reno, Nevada, and Dave is currently up in Hood River, Oregon. We both kind of run our own different pain management clinics. I mean, we both do the same thing, and have been friends and colleagues, Dave, for a very long time. Dave and I met actually interviewing for residency to do a physical medicine rehabilitation residency program at the University of Washington, and ended up doing our PM&R residency at the Mayo Clinic together. So Dave and I have known each other for a very long time, and I always give Dave credit. I wouldn't be doing pain management if it wasn't for Dr. Russo. Dave convinced me to do a pain fellowship when I was dead set on being a sports medicine physician. So Dave, thanks for leading the way. Since graduating, Dave and I both have gotten board certifications in physical medicine rehabilitation and pain medicine. I think we both just did a recertification a couple of years ago. In 2009, I started my clinic, Nevada Advanced Pain Specialists. Our clinic has grown leaps and bounds. We now have 3 different clinics, one in Sparks, Reno, and Carson City, Nevada. On 2 different occasions, I've been voted one of the top 25 doctors in Northern Nevada. And actually, during the middle of the pandemic in 2021, I got voted the 2021 Innovator of the Year. So it's kind of been quite a ride. Dr. Russo, I think immediately upon graduating, took over control of Columbia Pain Medicine Pain Clinic. He's been running that clinic now for 15 years up in Hood River, and is a well-astute physician in regenerative medicine. And actually, that's why I'm sure Dave will talk about it tonight, that being accurate with your joint Bursa or even peripheral nerve injections when you're doing regenerative medicine is essential so that the patient gets the best result possible.
Yeah.
Here's Dave's and I's disclosures. And then our contact information. We are both open to you reaching out to us at any point after this presentation if you have any questions. I do encourage you tonight that we do have a Q&A section. Please write in any questions you may have. We'll try to answer them during the presentation. If not, we will get to them hopefully at the very end during our live segment. And we're going to start it off with having Dr. Russo go through actually the basics of ultrasound.
Fantastic. Okay, so Dennis, you're in charge of the up and down keys, and we'll kind of go through this. We'll kind of go through these introductory slides together. I think most of the participants probably already have a pretty solid sort of understanding of the physics of ultrasound, but just to kind of review on a high level. So basically what this modality involves, this diagnostic and imaging modality involves, is directing sound waves through the body and analyzing the reflections back to the probe in order to generate an image. And high frequency sound is used to get that image, and we measure the frequency in cycles per second. So we're dealing with high frequency ultrasound waves that are not audible to the human ear. So it's a very it's a very safe and accessible diagnostic modality that can be done at the at the point of care and at the bedside, and certainly, seeing it in a number of specialties ranging from orthopedics to pain medicine to ER. So it's really sort of becoming the next sort of modern stethoscope of our time for a number of specialties. So next slide. So the big idea here is that directing sound waves, into the body, frequency matters. So higher frequencies penetrate deeper than lower frequencies. And again, what you're seeing come back to the probe is both emitting the sound signal and sensing the reflection of the sound waves. So the real business part of any ultrasound system is in the probe. Most of the manufacturers have really gotten the electronics of the image processing piece of the equipment down to a very fine science, but you really want to ask about the frequency of the probes, their durability, the kind of arrays, the piezoelectrodes, because that's really going to be the piece of the equipment that's responsible for generating the best image quality. So things that appear bright on the ultrasound image are things that are reflecting sound waves back to the probe. Things that appear darker on the ultrasound image have more water content, and that represents sound waves being transmitted through the tissues. So next slide. Again, this kind of summarizes what I said previously. These piezoelectric crystals are both sort of the emitting and sensing component of the system. The amount of energy reflected equals the density of what you're looking at. So echolucent or hypoechoic substances or tissues contain water and are more transmissible of sound, and substances that are denser or brighter, such as bone, reflect most of those sound waves back, so they appear bright on the screen. Something to keep in mind is that, the ultrasound probe gets the best signal reflected back to it when it's perpendicular to the area of interest. So this gets into a concept called anisotropy, or sometimes you can affect the appearance of things on the screen by not being directly over them or perpendicular to the image that location that you're imaging. Next slide. Image resolution is key, especially when you're sort of directing your treatment to deeper structures or nerves or areas where there's a lot of vascularity, a lot of overlapping kinds of tissues. And color Doppler really becomes essential, especially when you're doing work around nerves, maybe hydrodissection around the brachial plexus or the carpal tunnel or other common areas of nerve entrapment. You really want to have that color Doppler feature available so you can differentiate vessels from other structures that you're trying to treat. Next slide. This kind of reiterates the concept that low frequency probes are more scanning probes. They send sound signals deeper into the tissues and are great for visualizing abdominal organs and deeper structures. Scanning superficial probes or high frequency probes are good for imaging nerves and tendon ligaments that are closer to the skin. Probes can come in various formats, so you'll hear about sort of long linear format, short linear format, or hockey stick transducer kind of format, small parts formats. All of these are just different configurations of the piezoelectric crystals inside the probe. So, again, the probe is really the business part of the system. Next slide. Lower frequency probes are great for analyzing deep abdominal structures. Next slide. Superficial structures. This would be an example of a short platform linear array high frequency transducer. So again, this is going to be very good for looking at muscles, tendons, ligaments, and relatively more superficial musculoskeletal structures. Next slide. A little bit about scanning technique. So unlike other diagnostic modalities that we might use, ultrasound is very much operator dependent. So you have to really be thoughtful about the patient positioning. Many of the procedures and injections we do sort of mimic the setups that we would use for anatomically guided procedures. But sometimes you do have to take into consideration sort of the ergonomics of the space that you're working in, and attention to sterile setup and sterile technique. This becomes especially important if you're considering incorporating any regenerative therapy injections into your practice, which all involve blood products. So usually what we look at is sterile gel and a sheath over the probe, and sometimes a long a long sheath kind of protecting the ultrasound probe and cord. Next slide. A little bit about knobology. So if you look at old ultrasound machines, or maybe some of the ultrasound machines you see in the diagnostic imaging department at your hospital, you'll notice there's a lot of different sliders and knobs. These are all sort of there to kind of help with calibration of the ultrasound signal. Many of the newer machines that are sort of designed to be more for point of care or bedside use kind of use kind of pre-programmed or preset functions or kind of software running in the background. But really what you're trying to do is fine tune the depth of the ultrasound down into that focal range where you're scanning the structure of interest. So what you're trying to do is overcome the phenomenon of attenuation, which is as ultrasound waves get propagated through the tissues, they become smaller as they penetrate the tissue. So that's overcome by adjusting the gain. And the newer machines have built into them algorithms based upon various depths of tissues or various kinds of anatomical structures you're looking at, so that this time gain compensation feature sort of happens in the background. So it's wonderful software to really facilitate the ease of scanning patients and performing injections, but also important to understand sort of the underlying physics in the background that are being optimized to generate the image. Next slide. A little bit about some terminology that ultrasonographers will use in the space of diagnostic imaging. Of course, we're very familiar with axial and transverse images to a structure. In ultrasonography, we also look at a lot of structures sort of in their anatomical plane, which may not be the same as the plane of the person. So a lot of structures are at oblique angles to things that we're interested in. So, you'll often hear people who do a lot of ultrasound guided procedures talk about being, long to X, Y, and Z, looking at a structure in its long axis or its short axis versus looking at it in its anatomical plane. So just a little bit of a kind of clarification of those concepts. Next slide. So, an ounce of prevention is worth a pound of cure, as they say. So things that you can do to kind of help facilitate your sort of development of proficiency in this operator dependent modality is to learn to be ambidextrous to the extent that you can. It is very helpful to sort of scan, to have a scanning hand and an injecting hand, and then being able to switch between the two. That's very helpful instead of having to reconfigure your room or go to the other side of the patient. Keeping contact with the patient. So oftentimes when I see people who are new to doing these sorts of injections or new to the use of ultrasound, they're holding the ultrasound probe higher up near its attachment to the cord. That's a very flippy floppy way to hold the cord, to hold the probe, if you will. So really sort of coming down and having your contact at the base of the probe or at the tip of the probe and contacting with the patient is the best way to kind of keep control of the situation and perform the injection as safely as possible. Also, taking a moment to visualize the structures of interest and the structures around the area that you're trying to treat, that goes a long way. Not everyone has read the same Netter anatomy book that we all studied, and you do see plenty of anatomical variations, especially in the musculoskeletal realm. And then there are a number of good phantoms that are available on the market, and those are fun and useful to practice with, to kind of, again, develop that eye-hand coordination and that facility with switching between hands. So Dennis, do you want to talk to us about some tips? Just a little sort of tip here before I sort of hand this back to Dennis is kind of the concept of jiggle. So as you're kind of learning to do these injections, sometimes it's helpful to sort of introduce a little bit of back and forth movement into the needle to improve its visibility. So Dennis here is showing us, a needle coming down into a structure, and there's a little bit of kind of back and forth movement or jiggle to kind of help kind of draw your eye to the area where you're trying to inject. And with that, I'll let Dennis take us through the next set of slides.
Yeah, so let me move the slides forward. So as Dave was talking about, he's talking about different techs or about the ultrasound machine. And I think being able to optimize and get your ultrasound machine to give you the best resolution possible of not only one, the patient structures, but two, your target, allows you to end up getting the best results while injecting the patient. But if you look at here, there's a couple different reasons why you can have failure. Number one, if you're coming in plane and your needle gets out from underneath the ultrasound. So if you look here, you've got an injection bottom left where you've got an anatomical structure that's oblique. You've got your probe along the top of it. You're coming out of plane with your injection needle. Where you're going to see the needles where it's only underneath the probe, right? So the needle tip is past, and so you're not going to see that, and so you can miss where you're injecting. So you always want to, if you're going to come out of plane, you're going to want to come, next to it, get the needle tip right underneath the probe. If you're coming in plane, it would be on the either edge of the ultrasound probe. You're going to want to go along the probe and make sure your needle tip doesn't veer off to the right or the left, so that you're always in plane with your probe, or the needle's always in plane with your probe. And that brings us to needles, where I think can also bring another huge advantage. So not only getting better at maximizing your ultrasound machine, but the equipment or that you use can also increase your visibility of your needle. And so there's a couple different choices that you're going to make with your needle. First one's going to be, what size needle are you going to use? Are you going to use a 22 gauge, or are you going to use a 25 gauge? There's a couple of advantages and disadvantages to these. One, a 25 gauge needle may hurt less for a patient, but it's going to be quite a bit floppier. So it may catch tissues and kind of bend a little bit. It may be harder to keep in plane. A 22 gauge needle may hurt a little bit more for the patient because it's a little bit thicker, but it's not going to bend as much, and it'll be easier to keep more in plane while doing your injections. Two, you can have blunt-ended needles. So those usually hurt a little bit more when poking the patient. Sharper ones are less painful, but the advantage of the dull needle is that you're not going to hurt any vital structures if you poke them. With a sharp needle, you could do more harm than good if you do poke a nerve or any other vital structure or vascular structure specifically. And then the other thing that I want to highlight is that your needle, the surface of the needle, do you go for a hypoechoic needle, which means that it's harder to see, or do you go with a hyperechoic needle? And that's what we're trying to show here on the left, is a hyperechoic needle that under your ultrasound, it will reflect the beam back to the probe and pick up a better signal. And that's what Payung is trying to do. So they've got two different types of needles. They got a Sono MSK and a Sonoflex. The Sono MSK is more for musculoskeletal injections. Dave and I are going to be highlighting that. The Sonoflex is going to be more for your peripheral nerve injections, and basically you can stimulate the nerve. So you get the needle in place, and then you can use stimulation to stimulate the nerve to make sure that you've got adequate placement. Now, these cornerstone reflectors, what they're essentially doing on the covering of this needle is that they're maximizing the amount of waves that return to the ultrasound so that the needle shows up better. And the great part about these are they're at different angles, so it doesn't matter what angle your needle is at. So if we look here below, we see a needle that's at, which would usually normally with a hypoechoic needle give you your best image, is because as the ultrasound waves come down, they're going to come back, and it's going to hit almost perpendicular to it, because you're almost going parallel with the surface of the transducer. But usually when you get steeper, so here you're probably at a 45-degree angle, and on the right one you're probably at a 70 or 80-degree angle. Usually those beams would come down, hit, and miss the ultrasound because they get reflected at that angle, which instead of going back up perpendicular to the probe. And so these cornerstone reflectors being set on the surface of the needle at different angles allows that to be reflected back that perpendicularly to the transducer to show up. And so you can see that it doesn't matter what angle you're at, you can still see your needle. So the biggest things that I just want to give you the key takeaways about these needles is that they allow you to see your needle, which means you can be quicker with doing the procedure. You can be safer because you know where your needle tip is going to be at all times, and you're not going to hit a neurovascular structure. And they can also, the procedure can be done at any angle, whether it's in plane or out of plane, 30-degree angle or a 70 or 80-degree angle, that you're still going to get reflection of the needle back to the ultrasound probe. They're also going to give you improved tactile feedback. And at the end of the day, you're just looking to get the best outcome you can. So if you know where your needle tip hit the structure and the injection was done properly, that's going to give you the best results. Plus, it's going to give you that safety that you're not going to cause your patient any harm at all during the procedure. And that kind of brings us, previously I've done a ultrasound and MSK presentation with our colleague, Dr. Rosenblum. He also goes in a little bit more detail with the basics of ultrasound. So if you're interested in the topic of ultrasound and want to learn more, I'd encourage you to go to Payum's YouTube page. They have a lot of different videos showing a lot of different procedures, and then it even includes mine and Dr. Rosenblum's previous presentation, which talks about other injections that aren't going to be presented tonight, plus more in detail regarding ultrasound principles and best practices. Which now brings us to our main topic tonight, injections in the pain clinic. When I was asked to do this presentation, I just went back through 3 months of my clinic to find what the most common joint and bursa injections that I did under ultrasound. What I found is that there are glenohumeral joint injections, subacromial bursa injections, and intra-articular hip injections. What I'm going to do now is I'm going to turn it over to Dave. Dave's going to go over the shoulder, the 2 shoulder injections, and then I'm going to retake over and talk about the hip injections. But I always just want to remind people that before we talk about the injections, why are we doing, or how do we select which procedure is correct to do? And, when I talk to residents at the University of Nevada, Reno, we always talk about how probably the most important thing is talking to your patients. The mystery is in the history. If you can talk to a patient and know the right questions to ask, you probably already know what's going on with them before you lay a finger on them. The second thing is the physical exam. The physical exam is crucial because now that should confirm what I'm thinking based off of the history that I got out of the patient. And then the third thing I look for is just the icing on the cake, and that is imaging to confirm what I believe by their history and physical examination. I tell patients all the time, I try not to look at the imaging until I've gotten their history and done their physical exam, because I don't want the imaging to bias my opinion. I think we all know that there's been at least 4 or 5 clinical studies over the last 20 years showing that imaging on patients with no pain shows abnormalities in like 80% of patients. And so we would never treat an abnormal image where a patient has no pain. And so we need to make sure that the imaging finding correlates with the history and the physical examination. And Dave and I are physiatrists, so I believe in EMG studies if we're looking for neurological disorders, especially with the peripheral nerves. EMGs can pick up if there's a radiculopathy, plexopathy, mononeuropathy, and it even can tell you if there's certain muscle diseases and or neuromuscular junction disorders. And then overall, you're going to take the whole thing, the history of the physical examination, the imaging studies, and an EMG study if done, and get your best clinical impression to dictate what procedure you do. And then when you're doing the procedures, you're doing them for several reasons. One, you want them to be diagnostic. So if you block the proper structure, the pain goes away, then you know that that's the source of the patient's pain. If you if it is diagnostic, then overall you're hoping to decrease the patient's pain, improve their function. I think we've all realized that pain scores aren't the end all be all. Being able to get our patients back to doing their normal activities of daily living and getting back to life is vital. And if you can decrease their pain, improve their function overall, you're going to improve their quality of life. At that point, I'm going to turn it back over to Dave to talk to us about the shoulder injections.
Okay, so let's talk about the glenohumeral joint injection. And I would just echo what Dennis said about, in any pain clinic or any musculoskeletal oriented clinic, shoulder, neck and low back pain are going to be among the two most common things you see. And about 1/3 of the time, what comes to you as a neck pain complaint is really a shoulder complaint. And about 1/3 of the time, what comes to you as a lumbar spine complaint or a low back pain complaint is really a hip or pelvis issue. So having good working understanding of the kind of somatic and musculoskeletal kind of mimickers of things like cervical and lumbosacral radiculopathy really goes a long way. So just a brief review of the anatomy of the shoulder joint. So the glenohumeral joint is a ball and socket joint, and it is actually the most mobile among the most mobile joints in the body. And what that comes at is the expense of stability. So by being the most mobile joint in the body, it's also the most vulnerable to instability. And its function is really made possible through its neuromuscular control. So the rotator cuff muscles and tendons that help keep the ball on the socket, if you will, it helps keep the humerus kind of onto the glenoid fossa. So the weakest part of the joint, of course, is the inferior portion. Its movements, as we're all aware, is flexion, extension, abduction, adduction, lateral rotation, medial rotation, circumduction. And the reason why it's important to really take patients through both an active and passive range of motion of this particular joint is it's going to really help you sort of refine your differential diagnosis of what structure it could be the pain generator. Is this more of a labral type pain generator or a tendon type pain generator or interarticular, extraarticular? So again, knowing how these tissues function in this joint is important for understanding what the differential diagnosis of a neck shoulder complaint could be. So next slide. So glenohumeral joints injections are indicated when you think that the cause of the pain is coming from inside the joint. So what structures are inside the joint? There's the labrum, there's the cartilage, and you're trying to direct your diagnostic injection or your therapeutic injection into the structures, toward the interarticular structures. So physical examination may show reduced passive range of motion. There may be clicking, there may be mechanical blocks to motion. There may be certain impingement maneuvers or certain kinds of positions where the joint feels unstable or the patient feels apprehensive. Those are all clues that lead you to think about an interarticular glenohumeral joint injection. So next slide. the probe you're going to use in most all cases, you're going to use a linear probe because you're going to want to differentiate between some of these structures like labrum, bone, and tendon. There are patients who have, a significant thicker body habitus where even a really good high frequency linear probe doesn't penetrate as deeply as you need to see those targets. But most of the time, a good high frequency linear probe will get you there. 22 gauge, 3.5-inch needle is usually sufficient. And then if this is a diagnostic or therapeutic injection, you want some combination of a local anesthetic and ropivacaine. If it's an orthobiologic injection, you may be looking at something like hyaluronic acid or platelet-rich plasma type solution as well. So next slide. This basically shows the setup. This shows that technique I was talking about having good hand control of the probe. So you have the operator's hand both contacting the probe and contacting the patient. They're down towards, what I call the business end of the probe. They're able to stabilize their hand well on the patient. And they're kind of looking at that posterior kind of aspect of the shoulder. So scanning probably superiorly and inferiorly to kind of find that ball and socket or that golf ball on a tee appearance of the glenohumeral joint. So next slide. And I think what we're going to see here is a demonstration of an out-of-plane approach to injecting that joint. And again, very useful to know both in-plane and out-of-plane approaches. So let's play this slide and look at this injection. So here we have a probe across the joint. You see that golf ball on a tee type appearance, local skin wheel just to kind of help facilitate the comfort of the patient. Identify the labrum, trying to avoid the labrum, but you want to see that little tip of the needle come down right in between that ball and socket. So we're going to look for it. We can see it. So coming back and forth and kind of walking down into the joint. This is a great technique. So walking down into the joint. When you feel yourself engage the joint, you inject with your injecting hand. Oftentimes you can actually visualize the injectate going down into that golf ball on a tee type structure. And that is a very successful, well-performed out-of-plane injection. So this is an example from my clinic this week of an in-plane injection. So here the joint looks a little different, but on the left side, we see a standard 22 gauge Quinky needle. We're going to see the needle come down through the skin and the overlying deltoid and kind of work its way down to that little kind of crevice appearing area down in the joint. So you see a little bit of tissue jiggle as I'm kind of making my way down into that glenohumeral joint. And we're going to see the same injection done on the same patient using a more conspicuous needle like the Sono MSK. So here, same approach coming in under the probe in plane. You can see already that the needle is more easily visible. And again, I'm scanning back and forth just a little bit, kind of comforting the patient as we kind of get the injection going. Here we see a nice bright hyperocoat needle coming down into that crevice area where the injection will be performed. And that is a long axis approach to the glenohumeral joint in plane long axis approach to the joint. Okay, next slide. Subacromial Bursa injection. So a subacromial Bursa injection is injecting into what I like to think of as sort of the potential space between the joints and tendons of the shoulder. This is a very useful injection in older patients who may have significant arthritis, osteophytic spurring. They may have contractures or other issues that make positioning difficult. So injecting into the subacromial bursa is a good way to indirectly target the joint. The bursa communicates with the joint, but it also communicates with other periarticular structures. So what you lose here is you lose diagnostic specificity with this injection. So this is uncommonly done on a diagnostic basis. This is more of a kind of a more generalized approach to treating kind of whole shoulder pathology. So we're injecting into the subacromial space right under the deltoid and right under the acromion of the shoulder. So next slide. Indications here is like I described, it's more for a subacromial bursitis. So bursitis manifests itself when you have a joint that's producing a lot of synovium, and that synovial fluid sort of needs a place to go. So oftentimes these bursas are kind of low pressure release valves for a joint that's got some interarticular pathology. There may be an impingement syndrome where the patient has pain with certain ranges of motion, and that bursa is getting irritated. A rotator cuff tendinopathy, you may be able to directly visualize changes at the tendon muscle or tendon bone interface. Physical examinations usually consistent for some kind of impingement maneuver or pain with a specific kind of range of motion, like external rotation in the shoulder. So that's what we typically see. We see weakness or pain with internal rotation of the shoulder, and that's an indication for this injection. So let's take a look at the next slide. Here we're going to use a linear ultrasound probe, same cocktail of injectate, if you will, a combination of a local anesthetic, a particulate steroid is fine for this injection. If you're using an orthobiologic, again, you'd be looking at something like a leukocyte poor platelet-rich plasma for this kind of injection, for a regenerative injection. Next slide. So here's the setup for a subacromial bursa injection. So what you want to appreciate here is that the position of the probe is more anterolateral on the shoulder, as opposed to the glenohumeral joint. So oftentimes what you do is you visualize the tip of the acromion. It's a big, bright, echogenic structure, very easy to find. Then you slide laterally kind of onto the deltoid region, and that's where you find, that's where you look for the potential space of the bursa that you'll see a hypoechoic line. So again, this is just kind of showing that location of the acromion and the subacromial space. So next slide. Same thing here. So here's an injection coming in. You see a little skin wheel, and then coming down into the joint, coming into the bursa location. So going right under the, kind of going right up to the lip of the acromion. This is from my clinic, so these are slides I'm a little familiar with. So here on the left we have a standard 22 gauge needle. You're seeing the tip of the acromion on the right side of the screen. You're going to see the needle come left to right into that hypoechoic space right above the tendon. So you're going to see some tissue jiggle as that needle kind of works its way down into that very thin hypoechoic space. Let's look at it with a more conspicuous needle, the Sono MSK. So again, coming in, again, it's automatically more easily visualized. I'm scanning back and forth a little bit, and again, you're able to see that needle and trace it all the way down into that thin hypoechoic area of the subacromial space. All right, Dennis, do you want to talk about the hip joint?
Yeah, so I'll take it over from here, and thanks. I was trying to highlight. Can you guys see out there, Dave? Can you verify for me when I use my mouse? Can you guys see when I'm highlighting the structures that you're talking about? No,
Dennis, your mouse is working great.
Oh, perfect, good. I'm glad to hear that. I'm trying to highlight when you were saying the acromion tip and the space. I was trying to highlight it with my mouse, so thank you. So yeah, I'm going to talk about the hip joint. So obviously the two shoulder injections that Dave talked about, you know, there is a blind technique. They can be done blind. You know, but from my perspective, you know, for not only for safety, but for the diagnostic purpose and to make sure I'm doing the right thing for a patient, I always want to do my injections, as I was saying, under some image guidance. And so, with the hip, there is no blind technique, and that's just because of the neurovascular structures in the area. You do not want to hit the femoral artery or the femoral nerve when performing this procedure. And so you can typically do this either under ultrasound or fluoroscopy, and ultrasound is much more portable, much easier to use versus doing this procedure under fluoroscopy, which usually, you're limited in your time with the fluoroscopy unit, either in your office or at a surgery center. So obviously we've got the hip joint, which consists of the acetabular, the femoral head, the femoral neck, and then you get the intertrochanteric line. And the great part about the hip joint is it's basically a big balloon, and all you got to do is get your needle inside the balloon. The actual balloon goes from the acetabulum all the way down to the intertrochanteric line. So for me, I don't concentrate on getting it into the joint space per se. I'm just getting inside the joint. And so my technique is to go down and touch on the femoral neck and inject, because I know inside the balloon or inside the hip joint, and the medication will then diffuse and get to where it needs to be. Main things that you're going to do in intra-articular hip injection are for either a internal derangement or osteoarthritis. Internal derangements can be, a labral tear, femoral acetabular syndrome. I think we all know those are usually in younger patients where they have a mismatch between the shape of the acetabulum or the head of the femur. They're usually going to notice pain with extreme flexion past 90 degrees. So it's usually track or runners that are typically going to have that. Hip osteoarthritis can be usually in our older population, and labral tears are also going to probably be more in your younger population. Typically on these patients, you're going to see a positive Faber or Fadir. So internal and external rotation with the hip at 90 degrees is where the patient's going to have pain. You can also have Stinchfield's, which is a positive hip flexion test. So the patient's kind of doing resisted hip flexion. It gets pain within the groin. It usually indicates that is also something inside the hip causing the pain. For this, since it's a deeper structure, we're going to use a curvilinear probe. So I'm not going to use a linear probe on this one. I need to see deeper to make sure that I can see my target. I'm typically going to use a 22 3.5 inch gauge needle. And then when I do the injection, I'm going to use about 4 cc's of bupivacaine for the diagnostic portion of the injection. Tell the patient they should feel good for about 5 or 6 hours that day. And then usually I want to use a particulate steroid if I'm using steroids. So I prefer Celestone, 6 milligrams, which is the equivalent of about 40 milligrams of Depomedrol. As I was saying earlier, there's no blind technique for this injection, so do not try to perform it blind. The ultrasound here, you'll see, here's the head of the patient up here to the right, the leg of the patient goes down here to the left. Once again, you're seeing, just like Dave was saying, you got excellent hand control of the ultrasound. So this is going to be where you have an oblique angle, because your femur is going to come up, the femoral neck is going to branch off at about a 45 to 60 degree angle into the acetabulum. You're just going to be just lateral to the groin. Looking at it from the head down to the feet, you can see that angle. So the femur would be coming through here, and then at that 45 to 60 degree angle, it'd be going up into the acetabulum, the femoral neck. And there, once again, is looking at the bottom up. And I just want to highlight this, and this is actually a case, once again, just like Dr. Russo showed cases from this week. This is a case I did this week. I actually did this Monday morning on a patient who is morbidly obese. I think their BMI had to be between 45 and 50. So you're going to see this was quite a struggle to not only see the patient's anatomy, proper anatomy, but really struggle to see a Quincke needle, and then follow it up by using the MSK. And my angle is probably about 60, 70 degrees here. So it's a very steep angle. So I'd expect to have a harder time seeing the Quinky needle. But you'll see the Soleno MSK needle definitely was more visible. I just want to kind of give you an idea what the anatomy is going to look like. So your labrum is going to be up here to the left, your humeral head is going to be right through here, and the neck is going to be right along here. My needle is going to come up on the top right and come almost at that 60-70 degree angle down and touch the femoral neck. So let's watch the Quinky one here. I'll actually turn off my commentary. So as you can see, I'm kind of scanning back and forth to try to visualize the neck as best I can. Boom. You can see here, I can see the femoral neck. I can see it scoop down and kind of go along. I think I even get a better stopping that. And eventually what you're going to see is I'm going to use a lot of those techniques that Dr. Russo was talking about, where I'm going to jiggle my needle to see it come down. So right about now is where the needle is going to enter. You can see it come in right here. You can see the femoral head right there. You can see it come down onto the neck right there. I'm kind of scanning in. So there's head, femoral neck right here. You can see this needle come down. I'm kind of jiggling it. I probably had to put this needle in about 3 inches to reach the target. And as you can see there, you rarely or never really saw much of the needle. It was all done by watching the tissue move. So exact same patient, exact same technique. Now you're going to see the Payunk needle. See how that needle almost lights up like a lightsaber at such a steep angle? You can see it go all the way down and in. Boom, we're all the way right there. Touched bone and injected. You can actually see how hyperechoic it is and much easier it was to see on such an obese patient. So at this point, I'm going to bring Dave back on. We're going to open it up to our Q&A. We've had 2 people, from what I can see, have sent in messages or regarding that, and I'm going to throw the first one out to Dr. Russo and get his opinion on it. And then if I have a different opinion, I'll chime in. If not, I'll just tell you I agree. Usually Dave and I agree on most things. But we have a Dr. Choker, I hope I'm saying that right. And he says, can you kindly tell me if you're going to insert a catheter for an interscaling brachial plexus injection, do you do it in plane or out of plane using the ultrasound?
That's a great question. So I've actually done it both ways, and a lot of it depends on sort of the patient's anatomy and clinical circumstances. I've seen some patients who've had some kind of radiation type treatments to the kind of upper quadrant and kind of neck shoulder area, and sometimes that's created some issues. I really think it depends on the unique anatomy of the patient. I've done it both ways and find them to be, equally satisfying.
Yeah, I agree with Dave. I think every patient's different, and you just got to go by what you can see using the ultrasound. If I had my choice, I would probably I kind of like out of plane in this. I usually like to put my transducer where I can see one scaling muscle on one end, the other on the other, and I can see the gap in between and come on the edge of the probe and go in between. But coming out of plane, is a little trickier, because you got to make sure that needle tip stays under your ultrasound probe so you don't lose track of it. But that's the technique I prefer.
Yeah, I think I would say that this is I like this question because I think it also highlights a general principle that it's good to know at least 2 ways to do any injection. And when it comes to like these anatomical variants, I mean, the variability in especially vascular anatomy, I don't think we always appreciate how much variability there is. So sometimes you see things in places that you just don't expect them. So being able to sort of change your approach on the fly and feel comfortable with that is a great benefit to the patient.
Yeah, I totally agree. You should always know different ways to skin the cat because the cat's never going to be the same. We got another question here, and basically it's a physician, a Dr. Maria Cristancho, writing in. She says that she regularly uses ultrasound for nerve blocks and joint injections, as well as some trigger point injections. And she really wants to be able to perform them faster, safer, and more reliable in her pain clinic. But she also has to take into account insurance reimbursement. And so as terms of, buying a hypoechoic versus a hyperechoic needle, how do you get around this or how can you justify, I guess, the cost for the better technology of needle? And I can tell you, Dave and I talk about this stuff all the time since we both own and run our own clinics. Do you want to chime in on this, Dave?
Yeah. Well, I mean, I have kind of two thoughts. Like, I totally get it. So, but an ounce of prevention is worth a pound of cure. So I would say if you're doing, a trigger, when I didn't use ultrasound, let me frame it this way. When I didn't use ultrasound, probably the most frightening injection I did in my clinic was like a thoracic trigger point injection. So having the ultrasound adds such a huge layer of safety, especially if you're sort of injecting around the cervicothoracic junction. And what price is that? I mean, really, it's patient safety. So I think maybe explaining to the patient the need for this kind of this kind of modality or this kind of needle in this kind of situation goes a long way. Also, it depends what you're injecting. So I do a lot of regenerative medicine in my practice. So this is a non-insurance service for the most part, and patients have a financial stake in the outcome. So I really need to be able to say with high credibility that, I got my injectate exactly where it needs to go. So in that situation, the cost is a little bit of a small, a small insurance premium on the whole process. But I certainly understand that everyone's practice economics are different, and it's a constant juggle.
Yeah, I think first thing, I think Dave is exactly right. I mean, one, I think I've gone to the billing and coding courses for pain management now for 2 decades. So I almost know the billing and coding better than my biller and coders in my office. So first things first is, one, if you're going to add ultrasound, is it inclusive to the procedure, meaning you can't charge extra for it? So you need to know that. So if you look at your CPT codes, there's large joints without ultrasound, and then there's with ultrasound. The with ultrasound does reimburse a little bit more for taking the time to use it. And then there's other injections, like the peripheral nerve injections or tendon injections, where ultrasound is not part of the code. And so that's a add-on code that you can get reimbursed for. So if you're going to use ultrasound, you're going to want to make sure that you are actually adding it, if necessary, to get paid for the extra time using ultrasound to do the procedure. So make sure that you're not leaving money on the table by not including that CPT code for the use of ultrasound if you can add it. And then if you are doing like a large joint injection, make sure you're using the right code that includes the ultrasound when using it, so you do get paid more to do it. Second thing is yeah, so if for me, I've been doing these for 15 years, and God, some weeks I can do up to 100 injections, and that's not just ultrasound, that's fluoroscopy and ultrasound. And I find now that my ultrasound injections I can get done in less than 30 seconds. So now I can double book an ultrasound patient on top of a fluoroscopy. I can get multiple in throughout the day. And in my opinion, the faster I can do them, the more I can double book, the more patients I can see that day, the more I can sleep better at night knowing that I've treated, I got my patients in efficiently. I know I did it safely, and I know that I'm not going to get phone calls later with some issue or a problem. And part of that process of being able to do these faster and safer is, maybe spending a little extra money on a needle that I can actually see that I've got the structure and give the patient the best chance of a good outcome. So if you're struggling, with ultrasound to see your needle and making sure you got the target, and that adds on another 5 minutes to the procedure versus being able to, doing it in 30 seconds, then the extra cost of that needle is going to be made up by the volume of how many more patients you're going to be able to see and treat during the day. We just got a comment that came in. It's not a question, from James Nelson. He says, "This has been very insightful. Thank you for the presentation." Well, James, I appreciate you tuning in today. I think at this point, there's no more questions. Dave, is there any other last thoughts you want to add?
Yeah, I guess I would just conclude with the
Whoop, kind of lost you there, Dave.
Yep.
Conclude with what?
I guess I would just conclude with the observation that when injecting high value injectates, be it viscosupplementation or autologous regenerative products, or any concern about altered anatomy, or in doing a new injection in an area of the body you're not used to treating, having that visibility is key. It's key to building confidence, and it's key to ensuring that the patient has a safe experience and a good outcome.
Perfect. And I just got a couple other things that I'm going to go through before I get my last slide. So feel free to reach out to Payonk. They'd be more than happy to get you different educational posters or information on their product and needles and different techniques for during certain injections. And then last but not least, I want to just remind everybody that tonight was part one with my dear friend, Dr. Russo. Dr. Rosenblum and myself are going to come back, and we're going to do popular peripheral nerve injections under ultrasound. I think specifically we're going to be doing, if I can remember correctly, occipital, ilial, inguinal, and lateral femoral cutaneous nerve blocks on December 1st. We would love to have you all come back and join us at that time. And yeah, my last thoughts are, thank you for joining us. Giving your patients the best outcome is always the thing you want to do. And to me, that's always making sure that I get the needle at the right structure. When I see a patient come back and tell me they didn't improve and didn't even get relief the day of the injection, if I did an injection blind or use suboptimal equipment or technology, the first question I have in my head is, one, did I miss? Did I not hit the target? Is that why they didn't get better? Or two, I got to wonder if I have the wrong diagnosis. And I never like to have that question in my head. And so always using image guidance with the best technology or needles available to me to ensure I got that target. I never once have to question if I missed or had a bad day. I just then know that, hey, diagnosis A that we thought it was is not it. Let's move on to diagnosis B and the appropriate procedure to treat that. So thanks again, everybody, for coming in tonight. We'll be mindful of your time. It's 5 p.m. and we will say good night. Thank you.